Hello, everyone, and welcome to our webinar. My name is Michael Ritt. I'm a patient educator with the Stephen and Barbara Slaggie Family Cancer Education Center at Mayo Clinic. I'll be moderating this session today. Today's webinar is about oncofertility. This session is going to be recorded. If you prefer not to be recorded, please feel free to leave the live session. Once available, the video recording will be posted in the video library on our cancer education blog on Mayo Clinic Connect. Mayo Clinic Connect is an online community where people can share experiences, find support, and exchange information with others. We encourage you to follow our cancer education blog on Mayo Clinic Connect to learn about our other offerings and to access additional education, support, and cancer-related resources. I put the link to the cancer education blog in the chat, so that's there for your reference. Feel free to check that out at your leisure. We are going to take questions today during the webinar, but we are not going to answer those questions until we're done presenting. So if you do have a question during the presentation, please drop them in the Q&A section of your Zoom main toolbar. I'm honored today to introduce our speaker, Katie Olson-Perard, a registered nurse with a master's in science of nursing, is here to discuss next steps and available options if cancer care may affect your ability to have children in the future. Katie, I'll turn it over to you for the presentation.
Hi, everybody. Like Michael said, I'm Katie. We're going to talk about oncofertility today in our AYA population. We are going to talk a lot about kind of the pre-treatment, but there is stuff that we can do post-treatment as well. And I will do kind of more of talking than what is on the slides regarding that. So what is oncofertility? So we have oncology, which is the study of cancer, and fertility, which is the capacity to produce offspring. So oncofertility is balancing life-preserving treatments with fertility-preserving options. And who's at risk? So cancer and cancer treatment can cause fertility challenges in as many as 80% of our young adult cancer survivors. So quite a few people are at risk, and a lot of our treatments we know does impact fertility. So here's our fertility preservation option. So this is usually before cancer treatment starts. For those with ovaries, we have egg and embryo cryopreservation, ovarian transposition, ovarian tissue cryopreservation. Ovarian protective medications are also available during treatment. If you guys are already on treatment, you may have heard of like Lupron. It is not an effective form of fertility preservation. It does try to help suppress the ovaries during the treatment to hopefully help. A lot of that is done during like the urgency of starting treatment. But our more golden standard is the egg and embryo cryopreservation if we are able. The ovarian tissue cryopreservation is when we either remove an ovary and freeze that or part of an ovary. And then the ovarian transposition is when we move the ovary to another area of the body, if that's like for radiation in that field or surgery in that field. And then for those with testes, there's sperm cryopreservation, pelvic shielding, and then a testicular sperm extraction, also known as a TESE. So for males, what can we expect with sperm banking? So we do labs prior to sperm banking. These are ID labs. So we want to make sure there's no infectious diseases going on. There will be masturbation required. You do get a private room. No ejaculation 2 to 7 days prior. So we want an ejaculation at least less than, you have to have one at least within a week, but no more than 2 days. So we have like this window of the 2 to 7 days. There's no lubrication allowed during sperm banking. There is visual stimulation allowed. You can bring your own material with you. No significant others or anybody allowed in the room during collection. We do try to get 2 to 3 samples prior to treatment starting just to get the best outcome of what the vials will contain. And they need to have at least 2 days in between the samples. If this is an urgent treatment start, we can do 1 sample we just are unsure of how much will be available in that one sample. If unable to produce a sample, we do consult urology for more support. There is a cost associated with this. Insurance sometimes does and sometimes does not cover. It is more reasonable than the ovarian stuff, but just so that you're aware, there is a cost, and then there is also a cost to keep the sperm frozen, and they bill that here at Mayo. If you got it done at Mayo, it is every 6 months the billing comes out. So for females, what can patients expect with egg retrieval? So here at Mayo, we do what's called a random start. You do not get that at every fertility location. A lot of fertility clinics want you to have it based off of your menstrual cycle, and then they tell you when to start the hormones based off of your menstrual cycle. Here we can start as a random start, just knowing that we need that urgency. We do, or you will do, 2 to 3 weeks of hormone stimulation, so self-injections. There is side effects that as comes with these medications as they're hormones, so bloating, cramping, headaches, things along those nature. You do, if you're here at Mayo, you will have to remain local for those labs because we do frequent labs, and then once the labs show a certain point, then they also do transvaginal ultrasounds to check on the ovaries and the egg production. Surgery is with anesthesia. What they do is they go in transvaginally and they make a small incision in the ovary and they get those eggs. And then no intercourse afterwards until the menses has returned. And the cost is a lot with this one. Again, insurance can or cannot, may or may not cover it. Minnesota is not a state that requires insurance to cover. They are working on it, but it's currently not a state yet. So we do have some grants and stuff that also helps. So questions to ask your provider. Understanding that this time is really hard with having an unexpected diagnosis and everything going on, we just put 3 main questions that can kind of be good icebreakers with your providers. So what's my risk of infertility or early menopause based on the cancer type and treatment plan? Will any fertility preservation options delay my treatment or influence my chance of recovery? And then can you recommend any fertility clinics which specialize in care of cancer survivors? Like I said, here at Mayo Clinic in Rochester, we do have our reproductive team here, and they're amazing. And we do have a urology. Mayo Clinic, Arizona, and I believe Florida as well do not have reproductive endocrinology on campus. So that would be asking for something outside of the clinic. And then here's some of those external resources with grants. So Livestrong Fertility, Verna's Purse, Walgreens, they all do help with storage fees. They can help with some of the medications that are for females for the hormonal medications. Team Maggie's Dream also gives grants. Worth the Wait Charity actually does fertility. And then if for some reason, we're on the after side of treatment and wanting children, they also do adoption grants. And then just a couple other external resources, Alliance for Fertility Preservation and the Oncofertility Consortium. But I did want to bring up, I didn't bring this into there, but there is, after the fact, if you're off of treatment and you didn't have a chance to preserve fertility, we could still get you in with our reproductive team. They can still do some labs, see what everything looks like, kind of then go about the plan. If you, for some reason, had your uterus out but still have ovaries, there could be where we could get your eggs and have a surrogacy. For males, we can do donor sperm with your significant other. There's other ways, and an adoption as well. So there's other ways to kind of go down those roads if you're interested in. But again, we can, I'm happy to talk to you about it, but we can also get you in with our reproductive team or our urology team if we need to. And then those are just like those references from the slides. Okay, so the question is, what are the chances that I can be pregnant after an allo BMT? So I will be completely honest, we haven't expanded my role into heme. But I would recommend asking your provider for a referral for our REI once you are done with the treatment. And then that way they can go through and get labs and everything. Usually we recommend a few, like 4 to 6 months at least, being off of treatment, and then we can kind of do some labs and kind of go from there to know what your body is doing. And there's always a chance. So I don't want to say, I don't have a full percentage on like what the chances would be.
Looks like somebody dropped one in the chat too.
Okay, so I got another question here. We don't have any certificates that will be provided for this webinar. Sorry, the question was, will there be any certificates provided for the webinar? And no. Okay. Oh, that's the same one. Okay.
All right. Thank you all for your questions. I really appreciate it. At this time, I'm going to close out the webinar. Thank you for participating in our webinar. We hope the information was helpful for you. You can click on the link in the chat to learn more about our offerings and to access additional education support. When the webinar is ended, you'll be prompted to take a quick survey. We appreciate your willingness to fill out this survey, as your feedback is helpful to ensure we are offering educational opportunities that are valuable to you. We thank you for joining us today. Thank you, Katie, for your presentation. We hope you all have a wonderful rest of your day.